This explainer is based on the literature review Vestibular Function Testing, Interpretation for Physiotherapists, VHIT, Caloric, Rotational Chair, VEMP, published by Australian Dizziness Clinics, available at australiandizzinessclinics.com.
Okay, let's jump right in, shall we? Welcome back to part 2 of our explainer series on interpreting vestibular function testing. Today, we're locking in on 2 absolute heavy hitters, caloric testing and the rotational chair. You can think of these as the slow end and mid-frequency probes of vestibular function. Now, when you stack these up with a V-hit, they give you this brilliant, complete frequency map of your patient's vestibular system. But even more crucially, they tell you exactly what speed of head movement you need to be prescribing. So today, we're going to break down these reports, calculate canal paresis, and hopefully help you dodge a few classic clinical traps along the way.
Here's our roadmap for today. 1. The clinical paradox. 2. Caloric testing and Jongkees. 3. The bilateral shift. 4. Rotational chair testing. And 5. Frequency-matched prescription.
Section 1. The clinical paradox.
Picture this. A patient's report lands on your desk. It shows a perfectly normal video head impulse test, or V-hit, but totally abnormal caloric testing. Your first thought might be, wait, is the machine acting up? Did someone mess up the test? But here's the really fascinating part. This combination isn't contradictory at all. In fact, it's a classic presentation of an early compensated peripheral lesion. And realizing that reading these 2 tests together completely changes your prescription, well, that's a real game changer. This idea perfectly captures the audio equalizer concept of vestibular testing. It's like a giant puzzle, and you need all the pieces. See, an abnormal caloric test paired with a normal V-hit just means you've got low-frequency loss, but the high-frequency adaptation is preserved. Think of it this way. Calorics are your low-frequency probe. On the flip side, V-hit tests vary high frequencies. So a patient might have totally recovered their high-speed function, but still have some really profound low-speed deficits. Or, the exact opposite could be true. You absolutely have to interpret these as a frequency pair, rather than just duplicates of the same test. Section 2. Caloric testing and Jongkees. Let's talk bithermal caloric testing. This uses warm 44-degree and cool 30 degrees Celsius irrigation in each ear. What this is actually doing is provoking lateral canal-only stimulation at exactly 0.003 Hz. Now, to put that into perspective, 0.003 Hz is incredibly slow. We're talking way slower than your normal, everyday head movements. It's this highly isolated, hyperspecific test of the lateral canal's absolute low-end capacity. So, how do we make sense of this? The key is the Jongkees formula. This is what translates those temperature-induced nystagmus responses into concrete, actionable numbers. The formula essentially spits out 2 main values you really need to care about: canal paresis, which indicates lateralized weakness, and directional preponderance, which flags an asymmetric bias nystagmus. But what do these numbers actually tell us about the patient sitting in front of us? Well, this is where the greater than 25% rule comes into play. If that canal paresis hits over 25%, you're looking at significant lateralized lateral canal weakness. Think of your classic unilateral hypofunction, like a right superior division vestibular neuritis, for example. On the flip side, if you're seeing a directional preponderance over 25%, but without any canal paresis, that strongly suggests a central or compensatory bias rather than a direct peripheral end organ weakness. Nailing this down is absolutely crucial because it dictates your next move. Do you push forward with plane-specific gaze stabilization, or do you refer out for a central evaluation?
Section 3. The bilateral shift.
But what if the weakness isn't just on one side? What if both canals are failing the caloric test? If you're looking at the report and the total caloric response is under 25 degrees per second across both ears combined, you are officially dealing with bilateral vestibulopathy. And let me tell you, this is a total rehabilitation game changer. Bilateral weakness demands an immediate, sharp shift in our clinical approach because their fall risk is skyrocketing. If you miss this and treat them like a standard unilateral patient, you could literally be putting them in harm's way. You've got to pivot your plan, and here are the exact steps. Step 1, abandon standard gaze adaptation. VOR ×1 and ×2 exercises, they rely on having an intact vestibular system on at least one side to adapt. If both sides are severely weakened, adaptation just isn't going to cut it. Step 2, shift heavily to substitution vestibular rehabilitation therapy. We're talking about training the cervical ocular reflex, practicing anticipatory saccades, and really leaning into proprioceptive cueing. And step 3, review gait aids and ensure any balance work is strictly supervised. Their visual and proprioceptive systems are doing all the heavy lifting for their balance now, so having them do eyes closed standing on foam without someone right there, no way. The fall risk is just too high. Section 4,
rotational chair testing.
All right, let's explore the tool that perfectly fills the diagnostic gap between the extreme highs and the extreme lows. The rotational chair precisely tests the 0.01 to 0.64 hertz band. This beautifully bridges that mid-frequency gap between the extreme slow end of calorics, way down at 0.003 hertz, and the extreme high end of V-hit, which sits up at 1 to 6 hertz. The chair is essentially assessing lateral canal VOR gain and phase across these crucial mid-range frequencies.
And because of this mid-frequency coverage, rotation is actually way more sensitive than calorics for catching partial bilateral loss early on. Calorics are fantastic for finding severe, isolated lateral canal drops, for sure. But the rotational chair, it's going to pick up reduced gain and abnormal phase leads that point to bilateral peripheral hypofunction long before it shows up completely on a caloric test. It's also perfect for serial monitoring to track a patient's recovery. Plus, in your chronic, well-compensated patients where bedside tests have completely normalized, looking at gain symmetry on the rotational chair can help you finally lateralize that tricky lesion.
Section 5, Frequency-Matched Prescription.
Now let's bring all these numbers together and build a concrete treatment plan. This decision tree is fantastic because it shows how every single test pattern triggers a highly specific exercise emphasis. Unilateral canal loss on a V-hit or a caloric canal paresis over 25%, that points you straight to plane-specific VOR adaptation. Bilateral canal loss, that points directly to substitution training. And as we'll get into next time, otolith asymmetry pushes you toward otolith balance work. Reading the report accurately literally halves the time you'd otherwise waste on the wrong exercises, simply because you aren't guessing the mechanism.
If there's one ultimate clinical pearl to take away today, it's this. You have to match your exercise frequency to the exact deficit frequency. A generic one-size-fits-all prescription just doesn't work. If the rotational chair or calorics are showing a low frequency loss, you need to prescribe slower head turns, around 1 to 2 hertz for your VOR exercises. But if the V-hit shows a high frequency loss, you've got to prescribe fast head turns, around 4 to 6 hertz. What if they have an abnormal rotational chair, but a perfectly preserved V-hit? Well, then they need frequency-broadened training, where you prescribe both speeds. It's all about matching the exercise right to the deficit.
In video 3, we cover VEMP, CVEMP, and OVEMP, the otolith arm, and why missing it is the commonest reason a canal-targeted VRT plateaus when lateral pulsion or head tilt persists. You definitely won't want to miss that one because the otoliths are so often that missing piece of the puzzle. For more resources, literature review, clinical cheat sheet, audio overviews, and the rest of this series, visit AustralianDizzinessClinics.com. Please subscribe and leave a rating.